Good afternoon, everyone. My name is Tabby Kennedy. I'm from the University of Wisconsin, and I'm honored to be co-moderating the session today with Dr. Sakai on neuro-ophthalmologic imaging. Our third lecture in this session is going to be given by Dr. Quigley, who's an associate professor of radiology at the University of Utah. His topic for today is scotomas. Where do I need to look for pathology?
Hello, I'm Edward Quigley. Today I'll be talking about scotomas. Where do I need to look for pathology in orbit imaging? I would like to thank many of my friends and colleagues for excellent cases within this lecture. And I'd like to thank our superb group of residents and fellows in our 3D Advanced Visualization and Imaging Laboratory. And I'd like to thank the program committee and Dr. Schmalfus for such an outstanding virtual program. Today we'll be discussing several new entities and concepts in orbital imaging and reinforcing those concepts in some of the topics that have been discussed today. These include IgG4, anti-MOG, aquaporin, a new concept of Sclopetaria in trauma. We'll talk about diplopia and spread of tumors. So we'll also discuss the location for blind spots by their anatomic location. If we think about the various spaces that we can miss orbital findings, we'll consider the nasolacrimal apparatus and the medial canthi. We'll consider the lacrimal fossa. We'll look at the lens, the globe, the optic nerve, the extraocular muscles, the orbital apex, and then disease spreading from the lateral orbit or from the adjacent sinuses. And then we'll consider the cavernous sinus and vascular causes. And we have constant distractions. But looking at common misses, one of the most common was failure to consult prior studies or reports, limitations in imaging techniques that were available, either inappropriate or incomplete protocols, inaccurate or incomplete or frankly misleading history, a lesion outside the region of interest on an image that you're looking at, and then the classic satisfaction of search errors. So here's an example of an incomplete history. We have a patient with vision change. And while this frequently is the type of history we may be provided, sometimes we have too much information, we have to decode that. So this is a better history taken from the same patient's clinical note. And when you decode the acronyms, that's actually the clinical history. So once you've decoded that clinical history, then you have to make the decision about type of protocol for better orbital imaging. Decoding a good ophthalmologic history may really help you protocol that right study to decide whether you want to get a standard gadolinium orbit, a pre- or post-ganglionic Horner's protocol, a simple stroke protocol, or demyelination protocol of the brain. Thankfully, there's no shortage of acronyms in ophthalmologic evaluation. We've provided just a few here to help you translate those occasionally cryptic clinical notes. So when we consider blind spots in our routine imaging, we often cannot see the reported findings in the clinical note, like hyphema, injection, conjunctivitis, chemosis, or lacerations that are small, like iris or corneal lacerations. But we may be able to see secondary signs like lens dislocation, compartment collapse, blood in a segment, choroidal effusions, or retinal hemorrhages. So to help clarify some of the orbit terminology on things that we can't generally see on our imaging, let's consider hyphema, which is blood in the anterior chamber. Here we see it layering in the anterior chamber of the anterior segment. There's chemosis, which is edema or swelling of the bulbar conjunctiva, and that can get so severe that it can occlude vision. You can have a simple subconjunctival hemorrhage. Addressing the common miss of lesions outside our normal search pattern. Here's an example of a patient with history of melanoma, routine screening imaging. This is a routine brain. So some strategies that can be used are to prioritize non-indicated territories in your search pattern, or to use standardized reporting with forced interactions, for example. So here's that example of a lesion outside your normal search pattern. We have conventional imaging on this patient with imaging obtained for routine melanoma screening. Here we see a T1 hypo intense and intermediate lesion in the upper lid or on the conjunctival surface. When we look at axial imaging, we can see that it's involving the bulbar and tarsal conjunctiva. Here's T2 hyperintense. It enhances avidly. It's T2 hyperintense, and it has low ADC and some diffusion restriction. If we think about other blind spots in our technique and our methodology, there can be blind spots due to density. So frequently a penetrating trauma with an iso or hypodense object may be hard to perceive. So this patient had a left open globe with the anterior chamber collapsed, but you've made the finding, but then there's satisfaction of search error. And if you notice at this arrow, there's a small hypodense lesion, which is a fragment of wood. Now, over time, wood can change from dehydrated, as in this case where it's gas-filled, to hydrated and becoming hyperdense over the next 60 days. So if we consider anatomic location and imaging negative studies, molecular lacerations, lid and iris lacerations, these are often clinically evident to our colleagues but are imaging negatives, so we have to look for those secondary signs. So here's an example of a dog bite injury, and that laceration on imaging may be obscured by a dressing or edema, and these complications are often managed due to complications of a watering eye or drainage issues with a dacrocystorhinostomy. Here's a patient with an iris laceration from a penetrating corneal injury, but these patients may have an associated hyphema, which you may see on your reconstruction. So here we see a blood layer in the anterior chamber. Now, iris lacerations are clinically evident, but are very hard to demonstrate on imaging. So this patient has an iris laceration clinically on exam, but also has a hyphema in the anterior segment. The next orbital scotoma in imaging I'd like to address is naso-orbital ethmoid injury. So why is it a blind spot? Well, it's frequently something that we only can see well in axial imaging. It's often obscured by preseptal hematoma. The soft tissues of the canthal insertions we cannot perceive, so you have to really be aware of the anatomy. So the key imaging findings are fragmentation at the medial orbit and at the frontal process of the maxilla. And I like to use both the bone and the soft tissue algorithm to find these. The consequences are diplopia or nasolacrimal canal drainage issues. Here we see an osseous fragment at the medial orbit. Here's another case with bilateral naso-orbital ethmoidal fractures. We see the impaction of the nasal bones and the nasomaxillary buttress bilaterally, involving both nasolacrimal canals. So if we think about the buttress model of fractures, these involve the nasomaxillary buttresses of the facial skeleton, and as these fractures extend and deliver their energy to the cephalad, they're frequently associated with frontal sinus fractures. In the Markowitz classification, if you have a large fragment with the canthal insertion still attached, that's a Markowitz type 1. If you have additional comminution, that can make a surgical repair more complicated. In a type 2, the canthal insertion is on a smaller fragment which is displaced in addition to nasomaxillary buttress fractures. In a type 3, the canthal tendon has been avulsed from the comminution and fragmentation. So in this clinical picture, we see depression of the nasal bridge in a patient with a bilateral NOE, and during this maneuver, the globes moved laterally. So why is it so important? Well, the complications after you disarticulate the pulley system of the orbit is diplopia. And then you can have telecanthus from splaying of the canthal tendon. If it involves the cribriform plate, you can have a CSF leak or fractures involving the frontal sinuses. And then immediately you can have that nasolacrimal sac or duct injury, and then the medial canthal injury, which may often need to be repaired. The next imaging blind spot is the lacrimal fossa, and we should always consider lacrimal gland masses. Now, the anatomy of the lacrimal gland has the palpebral lobe and the orbital lobe separated by the levator palpebrae muscle aponeurosis, and so any pathology can involve either of those lobes. Things to look for are asymmetric enlargement, a change in density, or associated intraconal or extraconal fat stranding. And these pathologies can be unilateral or bilateral. So here we have a unilateral enlargement of the orbital segment of the lacrimal gland in a patient with IgG4. And if we take a closer look at why this lacrimal gland mass is in a blind spot. Well, this was imaging obtained for a routine history of a patient with pancreatitis and headache. So of course they get a routine stroke workup. And here we have the unilateral enlargement, lacrimal gland. But when we look a little bit farther down through the patient, we'll see that they also have associated parotid and submandibular gland involvement. So early detection of this lesion may lead to an earlier detection of the very protean IgG4 related disease complex. Here's a companion case of a patient with a cicatrizing process at the posterior globe, and this also turned out to be IgG4 related orbital disease. This can lead to a compartment syndrome and mass effect upon the orbital apex. Another lesion, this is a lung cancer metastases to the lacrimal gland straddling the palpebral and the orbital lobe with mass effect upon the globe. Here's a large mass being resected from the orbital lobe of the lacrimal gland. This was a well circumscribed lesion, and this was resected en bloc without spilling anything from the capsule. And this turned out to be a pleomorphic adenoma of the lacrimal gland orbital lobe. So moving on to our next blind spot location, let's look at the globe itself. So ocular lesions are frequently missed on CT and MRI, and why do we miss them? Well, satisfaction of search is a primary reason. These are images on the corner of the image, so we may have distracting findings. And this is an area frequently degraded by motion on MRI sequences. So the imaging features we must look for are intraocular masses, ocular thickening, scleral thickening, signs of inflammation, and occasionally some neoplastic lesions will also have associated choroidal hemorrhages. In this patient with a retinoblastoma, we see the vitreous expansion of the lesion, and here is the same lesion on enucleation. And this is the associated pathology of this retinoblastoma. So when considering ocular trauma, we must consider the anterior and posterior segments. Remember, we have a small anterior chamber in the anterior segment and a small potential posterior chamber that sits upon the vitreous face, and then the posterior segment has the vitreous with the central hyaloid canal, and then the retinal wraps around to form that ora serrata anteriorly at the vitreous face. So in this patient who had a penetrating injury, we have retinal detachment and vitreous hemorrhage. In this patient with a graphite pencil injury, we have an open globe, vitreous hemorrhage, a lens dislocation, and a through-and-through injury to the globe. Here we have another patient with a pencil-related injury, and this narrowly missed the medial aspect of the sclera and then was funneled through the orbital apex through the optic nerve into the middle cranial fossa. And as previously considered, always look at the four walls of the orbit to look for additional extension. The lens is a useful indicator if it is dislocated or subluxed. In this patient with an enlarged anterior chamber, that suggests that there is decompression and volume loss within the posterior segment, leading to sagging of the lens posteriorly, and then a normal appearance of the anterior chamber on the contralateral side. A critically important blind spot in orbital imaging is lens dislocation. In a pediatric patient, this should be considered a red flag to indicate a workup for non-accidental trauma in this case of a shaken infant. Further illustrate the importance of lens position in ocular injury, consider anterior segment rupture. The anterior chamber collapses, and while in a posterior segment open globe injury, there's vitreous leak and the lens sags and subsides posteriorly, but the anterior chamber can enlarge as the vitreous face recedes. So it's critically important to consider the change in position of the affected lens as the marker of trauma. Look at the anterior and posterior chambers. We can see motion effects upon the lens. So one should always consider the position of the lens in a trauma setting. We can have subluxation and dislocation of the lens. Here we have the lens migrating posteriorly, sitting on the optic disc within the vitreous. Here is another example of an open globe with a posterior segment injury, loss of volume, vitreous hemorrhage, and then the posterior dislocation and subsidence of the lens. Note that the anterior chamber is enlarged. In the setting of trauma, every hyperdensity really should be evaluated, and one thing to consider is Terson syndrome, which is spontaneous intraocular hemorrhage in association with subarachnoid hemorrhage, trauma, or elevated intracranial pressures. For our surgical colleagues, it's always important to characterize where the lesion or fragments of a mass are located. This was a nail gun injury with an iris laceration located medially. Additional nail gun fragment was located. Many patients don't remember their trauma or has happened so remotely, and there can be a wide range of density from plant matter, wood, plastics, glass, graphite, silica, stone fragments, metal tool fragments. This patient came in with a history of diplopia and had scarring of their medial rectus from an unknown foreign object. This is an excellent case from the literature of a patient who came in for routine brain imaging and then had a significant metal artifact. So imaging was obtained showing a radiodense object located adjacent to the optic disc. Now, with all of these open globe injuries, let's consider the new concept of chorioretinitis sclopetaria. So this is inflammatory or fibrous scarring after a through and through open globe injury. So if you have a penetrating injury, you can have scarring at the level of the choroid and retina. In this patient with a visual field defect, ophthalmologically, you can see a scarring and retraction there. And on scanning imaging, you can also see the irregularity when you run through that area, which is a projectile weapon. So moving on to our next concept, if we have bilateral symmetric lesions, the symmetry can really obscure the ability to perceive that finding. So in this patient who had diffuse scleritis and posterior scleritis, that may be challenging to perceive. And there may not be much post-septal fat stranding early. So one can consider scleral thickening or thickening of the post-septal fat. If we do further imaging on this patient, we see there's some inflammation of the ears. And this was a patient with relapsing polychondritis, and you can see the inflammation of the sclera and globes. Here we see that circumferential thickening, which is bilaterally symmetric and extended posteriorly to the optic nerve. On axial imaging, we can see the classic inflammation of cartilaginous structures, as is commonly seen in relapsing polychondritis. Another blind spot in imaging is the multifaceted spectrum of infection. So we can have everything ranging from a very subtle preseptal cellulitis to involvement of the nasolacrimal apparatus in this dacryocystitis. Or you can have inflammation of the lacrimal gland with dacroadenitis in this patient with lacrimal gland abscesses. In pediatric patients, you can have extension of adjacent sinus disease with subperiosteal abscesses and critical mass effect. In this patient with severe orbital cellulitis, we see stranding, stretching of the optic nerve, tenting of the globe, and this is a vision endangering event. And we want to avoid the final complications or endophthalmitis and panophthalmitis leading to enucleation or evisceration. Our next blind spot is optic nerve injury and inflammation. So in deceleration events, you can have a stretch injury and avulse the optic nerve from the optic nerve head. The optic nerve can also be involved from compartment syndromes and orbital apex syndromes, or from compressive neuropathy or mass effect at the annulus of Zinn. So if one imagines the eye as a compartment under pressure, the orbit can only decompress so much through proptosis, and this can lead to elevated intraorbital pressures, which can endanger the nerve. So in this patient with a large intraconal hematoma adjacent to the optic nerve and swelling, this is an emergent condition that you need to call, and this may lead to an emergency canthotomy. So in this situation, the orbit is decompressed anteriorly to provide room, and so you retract, you follow the dotted line, and do that medial canthotomy to open up that space and allow the pressure to decompress. But there's many ways to get to an compartment syndrome. It can be from hematoma, it can be from extension from disease from the sinuses, or it can be mass effect at the apex or the annulus of Zinn. So here we have another patient with an intraconal hematoma, and this was critically relevant because this patient had previously had an open globe injury with ptysis bulbi, and this was their one remaining eye. And you can see that orbital apex tracking, hematoma tracking back posteriorly. And this is an emergency finding that requires a phone call. Here's another orbital emergency that requires immediate intervention or evaluation. So here's a young patient with proptosis and ophthalmos, and we see a large subperiosteal abscess with mass effect upon the globe. Here's a different patient with disease extending from the frontal sinus, leading to a supromedial subperiosteal abscess with significant mass effect. And for our colleagues, it's really useful to report the volume of abscess. It's a new criteria for drain or not drain decision. The abscess is to help them decide about their critical surgical management. This is an example of orbital mass effect from inflammation. This patient who had no light perception in both eyes. You can see that marked bulbar conjunctivitis. But this is really coming from the extraocular muscle enlargement, which is bilateral and symmetric, with significant mass effect upon the optic nerve. And after surgical decompression of the orbit floors, the mass effect was decreased. Next imaging blind spot to continue along with is the optic nerve, and you really have to image the optic nerve from the retina all the way to the occipital lobe. We're looking at small structures, and particularly if you're trying to find anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, or non-arteritic ischemic optic neuropathy, and chase the optic nerve all the way back through the optic canal. So anterior ischemic optic neuropathy, why is it such a blind spot? Well, we're looking at a very small structure. There's very low signal on MRI. There's often motion limitations and susceptibility from the adjacent dental work or sinuses. The key imaging features to look at for is enhancement or diffusion hyperintensity. Here's a simple dot of diffusion hyperintensity at the optic disc. Here's a small amount of enhancement, unilateral, at the optic disc on that side in this patient who had a previous bout of optic atrophy, so a smaller nerve on the opposite side, that vision was impaired, and then a new lesion on the right. Now, posterior ischemic optic neuropathy, why is it a blind spot? Well, it occurs at the orbital apex, and this is frequently a site where we have diffusion artifact, and now this can be a rare complication of prone positioning or inversion. Usually anesthesia eye cups prevent ocular compression, but this can lead to, without these, you can have elevated intracranial or intraorbital pressures and get a compartment syndrome. So here we have a case from Dr. Winegar of bilateral posterior ischemic optic neuropathy. So here we have a case. So continuing optic neuritis and inflammation is another blind spot, and some of the newer concepts to consider are aquaporin P4 antibody-related neuromyelitis optica spectrum disorder, or anti-MOG. But remember, you can still have compressive optic neuritis or neuropathy. For example, in this case, we have a patient with orbital apex involvement related to IgG4, and this led to a compressive optic neuropathy of the optic nerve, left greater than right. Here you can see that stranding extending posteriorly. And notice the associated enhancement and pachymeningeal enhancement in this case of IgG4. When considering optic neuritis or neuromyelitis optica spectrum disorder, in the literature, about 65% were positive for aquaporin 4, and 7% of the remainder, or 7%, were positive for myelin oligodendroglycoprotein reactivity. So about 1/5 of the aquaporin negative were MOG positive. So this is where clinical history will really help with your blind spot in terms of optic neuritis. So with anti-MOG, which is anti-myelin oligodendroglycoprotein, these patients frequently have more optic neuritis. They're frequently male, often bilateral. They have less cord involvement and often present with a single attack. So here we have a patient with bilateral optic neuritis related to anti-MOG. So our next blind spot is orbital metastases. So why it's a blind spot? We're often focused on the brain, and we may have serial follow-up fatigue. The key imaging findings are an intraorbital or an intraocular mass, a melanoma met with an associated choroidal hemorrhage. Here you can see that choroidal hemorrhage wrapping around. There's the met, there's the hemorrhage. Here's another case. This is a pancreatic metastases that became an intraconal mass touching the lateral rectus and the optic nerve. Here you can see it on the coronal reconstruction. The patient had diplopia as their presentation. Here's another case. This is an intraocular melanoma, and this had an unusual finding of optic nerve sheath perineuritis. So here's the intraocular melanoma, and if we follow the back posteriorly, there's optic nerve sheath perineuritis extending posteriorly all the way back to the orbital apex. Patient had related optic nerve atrophy. Here's that T2 hyperintense prechiasmatic segment. Here's another metastatic lesion. This is carcinoid. It was initially presented as a well-circumscribed lesion. On T2 imaging, you see that optic nerve sheath cuffing, and then there was more infiltration later as it progressed, and mass effect after treatment. There was retraction, and there was some enophthalmos after the treatment effect. So there's that classic cicatrization seen with carcinoid in this beautiful case from Dr. Winegar. Metabolic activity associated with this lesion mid-therapy. So here's a bilateral case of infiltrative intraconal masses, and symmetry is your friend until it's not. This patient had some distracting leptomeningeal carcinomatosis, but here you can sort of see the evil gray of intermediate loss of that normal fat in the orbit. And this patient had both extraconal and intraconal disease, and here you can also see leptomeningeal carcinomatosis. This is not a failure of fat suppression. This is actually all disease. There you can see that leptomeningeal carcinomatosis. This is another blind spot which I find very challenging in orbital metastatic disease, and that's the iridial metastases. So here we have a melanoma met. If you're well caffeinated, you may pick this up on CT. Here we have the mass on T2. It's intrinsically T1 bright. It enhances avidly. Here it is growing over time. Or blind spot is seen with extension of sinus disease or anatomic variants of sinus disease. So acute invasive fungal rhinosinusitis can be a lethal combination in terms of orbital extension. So this stroke patient presented with some vision loss, and this diffusion hyperintensity in the posterior orbital apex was present. Here we see inflammatory stranding at the orbital apex, and this was intrinsically T1 bright. Notice there was some adjacent sinus disease, and notice there is enhancement and inflammation related to this severe invasive fungal sinusitis. It got progressive. You can see extensions to the maxillary sinus. Here's diffusion restriction within the optic nerve, and this led to exenteration and evisceration of the orbit to remove that devascularized tissue. Here's another example. This patient presented with mild sinus disease and fat stranding in the medial orbit. notice the normal fat and the stranding on the left. On MRI, there's completely devascularized mucosa, and this is a direct intraorbital extension. Notice the proptosis. As the disease progressed, we see that there's marked swelling, involvement of the orbit, extension back to the orbital apex, to the cavernous sinus, and then cavernous sinus thrombosis. Our next blind spot is to consider surgical pitfalls from anatomic variants or obscured landmarks. One must always consider onodi cells or pneumatized opticocarotid recesses. So here's a patient with an onodi cell posteriorly. This can lead to extension of sinus surgery to areas that are unintended, such as the orbital apex. Here's an pneumatized opticocarotid recess, but sinus disease there can extend and involve the optic canal. Here's a patient with that very thin optic strut right next to the optic nerve in a normal variant case. Here's an unfortunate trauma patient where that optic strut fractured and impinged upon the optic nerve. Here's an example of a patient with sinus disease and an onodi air cell that led to changes in positioning. And here we see an osseous defect. There was intracranial gas. There was gas within the optic nerve sheath. And if we zoom in, we can see a small osseous fragment that was extended into the optic nerve from the sinus surgery. One of our last lateral mass effect blind spots is orbital extension from the suprazygomatic masticator space. So occasionally we'll have tumor in the suprazygomatic masticator space that'll actually go through the zygomaticotemporal suture directly into the orbit, and this can lead to perineural or perimuscular or periosteal extension back to the orbital apex. In this case, that was a squamous cell carcinoma that went through the lateral orbital wall, started off in the suprazygomatic masticator space. And also, lastly, always consider extension of vascular lesions. We may be looking for a stroke workup, but consider arterialized vessels when you have a CC fistula. Notice the arterialized enhancement of orbital, facial, and the superior ophthalmic vein. So in conclusion, we've tried to introduce some of the common orbital blind spots by location. We've tried to demonstrate examples of pathology in unusual or hard to detect locations. And we try to reinforce those newer concepts in inflammation, autoimmune disorders, and consequences of injury. And we'd like to reinforce the concept that adjacent structure disease can extend into the orbit, causing vision loss, vascular injury, or extension to the central skull base. Thank you very much.
Our next lecture will be given by Dr. Catherine Reinshagen, who's an assistant professor of radiology at Mass Eye and Ear, and she's going to be talking today about diplopia.
Thank you so much to Dr. Schmalfuss and the ASH&R Programming Committee for the kind invitation to speak to you today about diplopia. I have no relevant disclosures. Over the next few minutes, I'll discuss the clinical presentations of diplopia, review the key cranial nerve pathways, briefly discuss appropriate imaging investigations, and show some common and interesting patients who presented at our institution with diplopia. Now, diplopia can be broken down into monocular diplopia and binocular diplopia, and monocular diplopia is defined as seeing double with one eye open. These patients are typically not sent to us for imaging, as the pathology is typically ocular in nature. Binocular diplopia, on the other hand, refers to double vision with both eyes open, and it typically results from a dysfunction affecting the extraocular muscles. Our main starting point in determining a cause is to review the pathways of the three cranial nerves supplying the extraocular muscles. These are the third, fourth, and sixth cranial nerves. The third cranial nerve supplies the majority of the extraocular muscles, the medial, inferior, and superior rectus, and inferior oblique muscles, as well as the levator palpebrae superioris, and it also provides parasympathetic innervation to the pupil. The fourth cranial nerve supplies the superior oblique muscle, and the sixth supplies the lateral rectus muscle. Now, cranial nerve palsies can be challenging to diagnose, and sometimes these patients may not present directly to an ophthalmologist, so a description of what a clinician sees is what we may get instead. So let's quickly review how each palsy presents clinically. A cranial nerve 3 palsy has a typical down and out appearance of the affected eye. There can be ptosis if the levator palpebrae superioris is involved, and depending on the location of the lesion, pupil dilation can be seen. Here in the top image, you can see that the patient is directed to look to their right, but the left eye does not adduct, and the lid must be lifted to show the finding. So this would be in keeping with a left third cranial nerve palsy. In the bottom image, you can see the right eye ptosis, and when you lift the lid, in neutral gaze, the globe is down and out, and there is asymmetric right pupil dilation consistent with a right third nerve palsy. Acquired cranial nerve 3 palsies can be commonly due to microvascular disease, trauma, or compressive lesions such as an aneurysm or tumor in adults. Now, cranial nerve 4 palsy can be a little trickier to diagnose. These patients typically present with a vertical diplopia, worse with down gaze, and the patients may adopt a head tilt opposite to the side of abnormality to compensate. One can see a hypertropia or upward deviation of the affected side when they look towards the opposite side. Here in this patient with bilateral fourth nerve palsies due to trauma, the hypertropia is accentuated with ipsilateral head tilt. Now, to confuse things more, some patients can adopt a paradoxical head tilt where they tilt to the ipsilateral side to cause a wider separation of images so that patients can ignore, or the brain can ignore, one set of images. Now, because of this head tilt and vertical diplopia, a cranial nerve 4 palsy can sometimes be difficult to distinguish from a skew deviation, which is technically a vertical misalignment of the eyes thought to be due to damage of the pre-nuclear vestibular input at the level of the brainstem or cerebellum. Although with a very thorough neuro-ophthalmologic examination, this can be teased out, we will not infrequently see requisitions which say cranial nerve 4 palsy or skew deviation. Most commonly, cranial nerve 4 palsies are due to trauma or microvascular disease in adults and may not have imaging findings. Cranial nerve 6 palsy, on the other hand, causes a horizontal diplopia with decreased abduction of the abnormal eye. Here in this patient, one can see that the left eye does not abduct when gaze is to the left. Most commonly, microvascular disease or trauma are causes of cranial nerve 6 palsy, but due to a significant portion presenting with tumor or other causes of increased intracranial pressure, brain imaging is often necessary. Other terminology you may read for these patients can relate to globe misalignment, so you may see the term esotropia referring to an inward deviation of the globe, exotropia an outward deviation, hypertropia an upward deviation, and hypotropia a downward deviation. Interestingly, misalignment in children due to strabismus often does not present with a diplopia, as children can adapt and learn to ignore one set of images. There are also additional symptoms and signs that can help narrow down the cause of diplopia and are worth noting when you see them. For example, is there an associated headache, scalp tenderness, jaw claudication, which can be seen in the setting of giant cell arteritis? Are there constitutional symptoms suggesting lymphoproliferative disorder or maybe a more systemic inflammatory process? Is there worsening diplopia with fatigue suggesting a neuromuscular junction disorder such as myasthenia gravis? Are there orbital symptoms such as pain with eye movement, as can be seen with Tolosa Hunt, or myositis secondary to an inflammatory process like IgG4? Or is there visual loss suggesting a compressive lesion along the optic nerve? Additional signs such as ptosis and pupil involvement help to localize a third cranial nerve lesion. Nystagmus and internuclear ophthalmoplegia suggest a lesion along the internuclear pathway. Other cranial neuropathies can help to also localize a lesion. For example, if the facial nerve is involved, one may want to look carefully at the 6th cranial nerve pathway in the pons. Or is cranial nerve 5 associated, or other cranial nerves affecting extraocular motility? Think about looking at the cavernous sinus, given their close association with one another. Is there proptosis or enophthalmos? Or are any symptoms, particularly those not mapping to a specific cranial nerve, suggesting an orbital or sinus pathology? So let's review the cranial nerve pathways affecting extraocular motility and see where things can go wrong. Now, I won't go into too much detail regarding the supranuclear pathway, but suffice it to say that conjugate gaze interestingly requires involvement of multiple areas of the brain. It requires the occipital cortex for fixation and following movements, the parietal cortex for pursuit movements, which are those smooth tracking movements by the eye to keep an object of interest centered on the retina, the frontal cortex for voluntary movements, and the utriculovestibular ocular pathway for compensatory movements. Often pathology in the supranuclear pathway is a result of neurodegenerative disease or a more widespread metabolic disorder, and they do not typically present with an isolated binocular diplopia, but rather more widespread neurologic symptoms. The paramedian pontine reticular formation then receives input from those cortical centers and sends it to the ipsilateral cranial nerve 6 nucleus, which then sends signals through the internuclear pathway or the medial longitudinal fasciculus. Now, the internuclear pathway is an important pathway connecting the nuclei of cranial nerves 3, 4, 6, and 8 so that conjugate gaze is possible. We typically think of pathology of this pathway as manifesting as an internuclear ophthalmoplegia, or INO, which involves the cranial nerve 3 and 6 connection. This works so that when one eye abducts, the other can adduct to have conjugate gaze. Here, a patient will present with a horizontal diplopia, and when one tests saccades, moving the eye from side to side, one will see slowed adduction in the ipsilateral eye and an abducting nystagmus in the contralateral eye. The INO is named after the side of the adduction deficit. Here, from midbrain to pons, you can see the MLF pathway in blue. You can see it connecting the cranial nerve 6 nucleus, crossing over, and then affecting the contralateral 4th and 3rd cranial nerve nuclei. Now, the nuclei of cranial nerve 3 are actually a cluster of nuclei located in the midbrain at the level of the superior colliculus ventral to the cerebral aqueduct, whereas cranial nerve 4 is located immediately below cranial nerve 3 in the caudal midbrain, and the 6th nerve nucleus is located at the level of the facial colliculus in the pons near the floor of the 4th ventricle. Here you can see the cranial nerve 3 at the level of the midbrain, ventral to the cerebral aqueduct at the level of the superior colliculus, cranial nerve 4 just immediately below at the level of the inferior colliculus, and cranial nerve 6 at the level of the facial colliculus, these bumps along the back of the pons at the level of the 4th ventricle. The infranuclear pathway of cranial nerve 3 courses through the red nucleus and then exits the midbrain along the medial aspect of the cerebral peduncle between the posterior cerebral artery and superior cerebellar artery, and then passes through the cavernous sinus before branching into the superior and inferior divisions and entering the orbit through the superior orbital fissure. Interestingly, pupilomotor fibers and their blood supply are carried more superficially along the cisternal segment of the 3rd cranial nerve, which is why a compressive lesion such as an aneurysm causes pupil involvement. On the other hand, the main trunk of the neural bundle is supplied by the vasa vasorum, which is more centrally located, and thus ischemic lesions tend to spare the pupil. Ischemic lesions of the infranuclear 3rd nerve tend to resolve on their own, and there are typically no imaging findings. Now, the infranuclear pathway of cranial nerve 4 is interesting and unique because the axons cross midline and then exit the brainstem dorsally opposite to the nucleus. So a lesion affecting the right trochlear nucleus would affect the left superior oblique muscle. It also has the longest intracranial course and courses under the free edge of the tentorium in the trochlear groove. On high-resolution cisternographic sequences, one can see this nerve, and the use of the trochlear groove and cistern can be a helpful anatomic landmark for locating the tentorial segment of the 4th cranial nerve. This paper by Paul Bunch, Hilary Kelly, Dave Zander, and Hugh Curtin is very helpful for helping to trace the course of the tentorial segment of the 4th cranial nerve. The infranuclear pathway of cranial nerve 6 is shown here as it courses anteriorly and superiorly through the pons, courses through the prepontine cistern, and then enters Dorello's canal. It continues upward over the petrous ridge to the cavernous sinus and superior orbital fissure. Now, because of its tethered aspect at Dorello's canal, lesions causing increased intracranial pressure can result in an isolated 6th nerve palsy. The infranuclear course of the 7th cranial nerve also wraps around the 6th nerve nucleus, and thus lesions affecting the 6th nerve nucleus can also present with subtle 7th nerve findings. In the cavernous sinus, cranial nerve 3 can be readily seen in the superlateral cavernous sinus on high-resolution T1 post-contrast images, whereas the 4th and 6th cranial nerves are not as well seen due to their size, but can be approximated as just below the 3rd cranial nerve in the case of the 4th cranial nerve, or along the inferior aspect of the internal carotid artery in the case of the 6th cranial nerve. Because of their close proximity to one another in this location, pathology at the level of the cavernous sinus can commonly affect more than one cranial nerve and can also affect V1. Moving along, while we cannot directly see the neuromuscular junction on imaging, the main clinical pathology is one of ocular myasthenia gravis with a classic history of diplopia worsening with fatigue. Because ocular myasthenia has a high association with thymic disorders in about 85% of patients, the most common being thymic hyperplasia, CT chest imaging is often performed. It's also interesting that a minority of these patients, about 3 to 8%, have hyperthyroidism or Graves' disease. As shown in the orbital anatomy lecture, the end organs are the extraocular muscles, and they can themselves be affected by pathology. It's also interesting to note the LR-SR band, which is a connective tissue band that connects the lateral rectus to the superior muscle complex, and weakness of this band can also cause diplopia. Orbital masses at this level can also cause diplopia, but I will not go into detail about these as they have been covered in depth earlier in this session by Dr. Jane. So one's choice of imaging really depends on the level of disease suspected. So in patients with a supranuclear, internuclear, nuclear, and infranuclear pathology, MR brain with high-resolution images of the appropriate cranial nerve pathway is recommended. If you have a patient with a pupil-involving third nerve palsy, this warrants addition of a CTA or MRA to look for an aneurysm as a potential source of compression. If the history is concerning for ocular myasthenia gravis, a CT chest is warranted. And if there are additional or specific orbital signs or symptoms, particularly those not mapping to a cranial nerve, dedicated CT or MR at the face is recommended. So let's review some common and interesting cases that presented with diplopia. Our first case is a 51-year-old female who presented with bilateral internuclear ophthalmoplegia and bifacial weakness. So here we're thinking about that close association of the sixth nerve nucleus and the facial nerve course. Here you can see on the flare and post-contrast images, there's symmetric enhancement and flare hyperintense signal along the facial colliculus near the sixth nerve nucleus and medial longitudinal fasciculus pathway, bilaterally, thus accounting for the bilateral INO. She had additional lesions along the closal septal interface and T2 hyperintense lesions in her spinal cord. So this was a first-time presentation of multiple sclerosis manifesting as a bilateral internuclear ophthalmoplegia. Here's a companion case of a 69-year-old male who presented with a left INO, the left adducting deficit. He had an abnormal enhancing lesion with surrounding edema in the left midbrain in the expected location of the left cranial nerve 3 nucleus, and another lesion in the right frontal lobe. And the patient was found to have metastatic lung cancer presenting with a first-time left INO. Here's a 58-year-old female who woke with binocular diplopia and a right internuclear ophthalmoplegia with a right adduction deficit. Here the lesion demonstrates restricted diffusion is located along the upper dorsal pons along the MLF after it has gone to the contralateral side. This was treated as an infarct. So remember, in INO in younger patients, we commonly worry about demyelinating disease, but in INO in older patients makes us worry about infarct or METs. Here's a companion case where we have a 33-year-old male who presented with binocular diplopia, esotropia, worse on right gaze. So here we're thinking about a right sixth nerve palsy. Additional neurologic symptoms were also present. Here we have an enhancing T2 hyperintense lesion in the right pons along the infranuclear pathway of the right sixth cranial nerve. He also had multiple flare hyperintense and enhancing lesions, leading to a clinical diagnosis of relapsing remitting multiple sclerosis. Our next case is courtesy of my colleague, Mary Beth Kinane. This was a 79-year-old female who presented with a headache, down and out globe, and a fixed and dilated left pupil. And because of that history, we're really thinking about a pupil involving third nerve palsy, so a CTA was performed. Here you can see this partially thrombosed posterior communicating artery aneurysm resulting in compression of the left third cranial nerve. Our next case, courtesy of my other colleague, Amy Giuliano, shows a 71-year-old female with a history of breast cancer who presented with a left eye, down and out, and a right horner. In hindsight, this is probably more of an issue of an anisocoria and a pupil involving left third nerve palsy. Here you can see nodular enhancement along the cisternal segment of the left third cranial nerve with abnormal enhancement throughout the cisternal segment. Here again in coronal, you can see the same findings. She was tapped and found to have leptomeningeal carcinomatosis of her left third cranial nerve secondary to breast cancer. Our next case is a 76-year-old male with bilateral long-standing vertical double vision, alternating hypertropia. So he had a right hypertropia in left gaze and a left hypertropia in right gaze. So to us, that sounds like a bilateral fourth nerve palsy. On his imaging, we can see two enhancing rounded lesions along the tentorial segment of the fourth cranial nerves, here in comparison with the normal anatomy. These were consistent with bilateral fourth nerve schwannomas. Now, interestingly, he did not have a known diagnosis of NF2 or a known genetic mutation that we know of. Here's a similar case, but unilateral, presenting with a right hypertropia, slightly worse in left gaze, so fitting a right fourth nerve palsy. Here you can see another right fourth nerve schwannoma. Our next case is a 31-year-old male with a 1-year history of intermittent horizontal diplopia, left esotropia, more common on left gaze. So we're thinking about a left sixth nerve palsy. Here you can see a very T2 hyperintense lesion enhancing mass involving the clivus. Here you can see the typical appearance of a thumb sign, as well pushing on the pons and causing mass effect along the cisternal segment of the sixth cranial nerve and involvement of Dorello's canal. Unfortunately, this was a chordoma. Here's a companion case of an older adult with a right esotropia on right gaze and horizontal diplopia involving, so concerning for a right sixth nerve palsy. Here you can see a T2 hyperintense enhancing lesion involving the petroclival synchondrosis, more off midline, and this was consistent with a chondrosarcoma. Here's another companion case of an 84-year-old male who presented with a history of prostate cancer and a right sixth nerve palsy, easy to overlook, but you can see when you follow the course of the right sixth nerve, you can see abnormal sclerosis and marrow signal abnormality in the clivus. This was treated as a metastasis, and he was treated with radiation and his sixth nerve palsy resolved. So don't forget about the bony surrounding of the sixth nerve as well. On those same lines, a companion case here of a 22-year-old female who presented with right mastoiditis, ear pain, who developed blurry vision, and right facial paralysis. Here you can see abnormal fluid and enhancement within the right mastoid and petrous apex. She was treated with antibiotics and eventually a canal wall down mastoidectomy with resolution of her symptoms. So clinically, she was diagnosed as a petrous apicitis. But you can also think about the classic triad of Grad-Nigo syndrome, which classically involves trigeminal pain, which this patient did not have, diplopia from a sixth nerve palsy, and otitis media, petrous apicitis. Our next case is a 20-year-old male with left supraorbital eye pain, left ptosis, and anisocoria. He had a left exotropia and impaired adduction, upgaze, and downgaze. Here you can suspect something in the cavernous sinus because of the multiple cranial nerves involved, including B1. Here you can see the left third cranial nerve is expanded and enhancing in the cavernous sinus. Here's normal. This case was a case of presumed Tolosa Hunt, and the patient responded well to steroids. Our next case is a 42-year-old female who presented with binocular diplopia for 4 months, developed droopiness of both eyelids, worse at the end of the day, and was recently diagnosed with hyperthyroidism. So I know this is a head and neck conference, but we did do a CT chest at the eye and ear, and sure enough, you can see changes both related to her hyperthyroidism and enlarged hypodense thyroid gland here, as well as this abnormal soft tissue in the anterior mediastinum conforming to what would be expected as thymic tissue. And she had positive anti-acetylcholine receptor antibodies, so she is a case of myasthenia gravis with associated thymic hyperplasia. Our next case is an interesting case. He was a 57-year-old male who presented with multiple constitutional symptoms, scalp tenderness, and double vision, which was an oblique diplopia and upgaze. He had adopted a chin-up position to compensate, and there was a hypertropia bilaterally on lateral gaze, suggesting a bilateral superior oblique abnormality. Here on imaging, he had bilateral enlargement and enhancement of the superior oblique muscles with surrounding fat stranding, consistent with a bilateral superior oblique muscle myositis. He had an extensive rheumatologic workup, including a temporal artery biopsy to exclude giant cell arteritis, which was negative. But aside from a markedly elevated ESR and CRP, he did not quite fit criteria for a specific rheumatologic diagnosis. So he's being considered clinically as a myositis secondary to a systemic autoimmune condition. He was treated with prednisone with resolution of his symptoms. A companion case is a 61-year-old female presenting with a progressive painless diplopia, not different on right or left gaze. She had a confusing picture because she had a remote history of varicella zoster ophthalmicus extending to the left cavernous sinus years before, which had subsequently resolved, and she had no new rash this time. Here, the imaging findings are pretty classic for thyroid-associated orbitopathy, including sparing of the musculotendinous insertion and lateral rectus muscles. So she subsequently underwent thyroid testing after this MRI and was found to have new diagnosis of thyroid dysfunction. The next case is a 43-year-old female with history of binocular diplopia, right hypotropia not mapping to a cranial nerve pathway. Here you can see the LRSR band. That fibrous band connecting the lateral rectus and superior muscle complex is bowed superolaterally, and there's medial deviation of the superior rectus and inferior deviation of the lateral rectus muscle, suggestive of sagging eye syndrome, which results from weakening of this LRSR band. In contradistinction is this next case of a 58-year-old female with alternating esotropia, binocular diplopia, and bilateral myopia and staphyloma. Here you can see the staphylomatous globes pushing the lateral rectus inferiorly and the superior muscle complex medially, in this case of heavy eye syndrome. So in summary, we've reviewed the pathways and presentation of cranial nerves 3, 4, and 6, and the internuclear pathway of the medial longitudinal fasciculus. Remember, in cranial nerve 3, workup for a pupil involving third nerve palsy should include an MRA or CTA to exclude an aneurysm. In cranial nerve 4, we have a unique cranial nerve pathway where the nucleus is on the opposite side to the affected superior oblique muscle. It has the longest intracranial course and can be easily damaged in trauma. Try your best to follow the course and try and use the trochlear groove and cistern as helpful landmarks of the tentorial segments. In cranial nerve 6, remember to consider causes of increased intracranial pressure as a cause for an acquired sixth nerve palsy. And in INO, think about demyelinating disease in young patients and infarct or metastasis in older patients. A patient with diplopia worsening with fatigue warrants a CT chest to look for a commonly associated thymic lesion and ocular myasthenia gravis. And diplopia with orbital symptoms not tracking to a particular cranial nerve, consider a CT or MR of the face. Hopefully I've shown that the clinical signs and symptoms and knowledge of the key cranial nerve and internuclear pathways can frequently narrow the differential for binocular diplopia and tailor the appropriate imaging examination. Thank you so much for your attention.
And our final speaker in this session is our program chair and president-elect of the ASHNR. Dr. Schmalfuss is a professor of radiology at the University of Florida in Gainesville, and she's going to be talking today about orbital post-surgical changes, expected findings versus complications. Thank you so much and enjoy the rest of the meeting.
Our next presentation will be focusing on expected findings versus complication after orbital surgery. We will be in particular looking at orbital implants as there is a rising incidence of their placement because of the aging patient population. Because of that, it's not surprising to incidentally see those implants and post-surgical changes on CT and MRI studies of the head and neck region. Many radiologists are not familiar with those findings and do not know how to interpret these. Therefore, we will review expected imaging features of common procedures utilizing orbital implants, such as lens replacement, retinal detachment treatment options, surgical glaucoma therapies, and globe prosthesis placement. In addition, we will be discussing imaging appearances of potential complication of those surgical interventions. Let us start with lens replacement. The lenses are consisting of different materials, but more importantly, they present different features, with some lenses being rigid, some lenses foldable, and some lenses being something in between with some flexibility. Here we have one type of lenses that demonstrates a lens core and the attachment that keep the lens in place after implantation. During surgery, a small suction device is placed into the native lens, and the native lens is sectioned out while the capsule surrounding the lens remains intact and in place. Subsequently, the artificial lens is placed into the native capsule. If it's a foldable lens, only a small incision needs to be made, while when it's a rigid lens, a larger incision is required to be able to place the lens into the native capsule. Those little attachments help secure the artificial lens within the native capsule and prevent dislodgement. On CT, in this patient who had bilateral lens replacement, we see a dense lens on the right, which is related to silicone lens, while the acrylic lens on the left is more loosened, and both lenses are very straight in appearance in contrast to the typical lentiform shape of the native lens. Here on the sagittal images, you see the leaflets of the iris and the silicone lens in between. Many complications can be associated with lens replacement, and we will be going through these separately. Dislodgement of the lens is the most common complication. Typically, it occurs in posterior direction. In this patient, we have the wavy appearance of the iris, with the silicone lens being displaced posterior to the iris. The profound displacement is more apparent on the sagittal reformatted image, where we see the dense silicone lens posterior inferior to the iris itself. Anterior dislodgement is more settled in appearance, and if you don't look for it, you might miss it. Here we will be looking at the width or depth of the anterior chamber that is markedly shallow on the right when compared to the left. This is related to tilted dislodgement of the inferior aspect of the lens when compared to the superior attachment that remains maintained. Here we have a lens that is not centered between the iris. It's more medially and inferiorly positioned. This dislodgement was caused by folding of the inferior medial aspect of the lens, which can be a complication of the softer lenses. Some patients will develop post-surgical or secondary glaucoma after lens replacement surgery. Here we'll be again looking at the size of the anterior chamber with marked widening appreciated with the secondary glaucoma when compared to the normal side. This is really important to report. A secondary glaucoma can cause permanent vision loss if not treated in timely fashion. Some patients develop capsular fibrosis. This demarcates on CT as nodular density adjacent to the edge of the lens that is low in attenuation on T2 weighted images and shows marked enhancement on the post-contrasted T1 weighted images. Acute infection can occur anytime a patient underwent surgery. In this patient, we still see intraocular air in the eye cover, but notice also that there is marked enhancement of the lacrimal gland consistent with dacryoretinitis. This patient has a more profound infection of the globe after lens replacement treatment with marked thickening and enhancement of the sclera consistent with scleritis. If that is not treated in a timely fashion, this can cause the calcification of the sclera and or of the artificial lens. So what are the home take points for lens replacement? Prosthesis dislodgement is the most common complication and may be challenging to see on axial images. Because of that, I encourage you to always do sagittal reformations to better determine if the lens is tilted or what the degree of displacement is. And I always encourage you to look at those lenses in patients with trauma, because sometimes this lens displacement can cause the trauma or vice versa. And I have seen a subset of patients that presented with stroke-like symptoms that were related to prosthesis displacement, and you might be the first one indicating the true nature of the patient's problem. In addition, don't forget to look at secondary glaucoma that demarcates itself as widening of the anterior chamber. This is very important to report to avoid vision loss if not treated in timely fashion. Our next topic is retinal detachment therapies. There are different types, so with scleral banding being one type that can be performed with silicone or hydrogel. These can be done with rings and buckles. Here we have the ring demonstrated in the drawing and on this operative picture. And the buckles can assume different shapes and different lengths as shown in this drawing. In addition, intraocular insufflation can be performed with silicone injection or air, also referred to as pneumatic retinopexy. Both types have one intent, to bring the sclera closer to the retina. The sclera bending brings the sclera to the retina, while the intraocular insufflation, the retina to the sclera. Many times patients will have a combination of these different types of treatments to be able to control the retinal detachment in the same eye. Here we have a scleral ring. The silicone ring is hyperdense in nature on CT. It's partially overlapping in the inferior medial globe area, while the hydrogel ring is very low in attenuation, mimicking air on CT examination, represented by 2 dots in axial plane in the mid-orbit and as a curvilinear structure in the superior and inferior orbit. On MRI, these two are indistinguishable from each other, and often they will not be even visible or clearly visible to the reader unless the radiologist notices the deformity of the globe. Only occasionally the entire ring will be captured in the coronal plane. The scleral buckles can be out of silicone, as in this patient, so these will be just localized in nature and will be shaped and sized as needed. Often it will be associated with a scleral ring. You see the scleral ring very nicely on the reconstructed coronal image with the buckles adjacent to it superiorly and inferiorly. This can be also seen on MRI, but in general, those buckles are more difficult to appreciate, as you see here superiorly, while the inferior one is a little bit easier to see just because of that more squared configuration. Intrasilicone injection demarcates itself as high-density material within the vitreous body in comparison to the normal eye. On MRI, it assumes different signal intensities on different sequences, but one hallmark is the presence of chemical shift artifact that demarcates itself as a bright band anteriorly and a dark band posterior to the silicone on every single sequence. Pneumatic retinopathy is caused by insufflation of air into the globe. Typically, room air is not utilized because it gets absorbed relatively quickly. Different gases are typically used, and with it, you will see air within the globe for several weeks. Notice also that there is a silicone band associated with the pneumatic retinopathy. If you have air persistent more than 3 weeks, you need to raise a question of potential additional infection and relate that information to the clinician. Many patients, as mentioned before, will have a combination of treatments, as here demonstrated with hydrogel buckle, intraocular silicone injection, silicone band, and of course, notice that on MRI, the predominant finding that you will see is the intraocular silicone injection, while the other types are more challenging to appreciate. Complication can occur with band dislocation that often goes hand in hand with scleral invasion as well as silicone migration. Infection can also occur, but since we already seen a few examples, we'll be skipping it here. So the band dislodgement is typically very localized in nature and very abrupt, as seen here on CT and better on MRI, the deformity of the globe. Sometimes you will see quite circumferential wasting of the globe. This is often intentional, as some patients may require a close approximation of the sclera to the retina. So again, the key point is to look for abrupt and localized indentation, not circumferential indentation, to make the diagnosis of buccal dislodgement and or scleral invasion. The silicone migration typically occurs intracranially. Since silicone is lighter than CSF, it will be floating superior to the CSF. And you see here the similar density as the silicone in the orbit. And when you want to prove that you're dealing with intraventricular silicone, you can place the patient in a different position, such as here in prone position, where the silicone will again migrate to the superior portion to be superior to the CSF. On MRI, the hint that you're dealing with silicone is, again, that it has same signal intensity as in the orbit. but it also is surrounded completely by CSF and does not look like it's ependymal in origin. In addition, don't forget to look for the chemical shift artifact with a bright band anteriorly and dark band posteriorly that is even better appreciated on the magnified images and looks very similar to the chemical shift artifacts characteristics of the intraocular silicone. What are the home take points for retinal detachment therapy? Look for band dislodgement, demarcate itself as abrupt, localized deformity of the globe. Do not mistake that circumferential wasting of the globe as band dislodgement because it's often intentional in nature. Look for silicone migration that is typically intracranial in nature, and since silicone is lighter than CSF, it will be always superior to CSF, meaning that it will be floating and it will be moving depending on the head position. Don't forget to look for the chemical shift artifact on MRI with the bright band anteriorly and the dark band posterior to the silicone focus. Let us move on now to glaucoma therapies. There are different devices as listed here. One of the devices that is interesting is this one, which is the beveled shunt. And the reason why it's interesting is because this device is barium coated, and because of that, it's more dense in appearance on CT and plain films than any of the other devices that are typically non-visible on plain films and difficult to appreciate on CT. In addition, there is an intraocular shunt that is also referred to as express shunt that is metallic in nature. So here we have the barium-coated beveled shunt that is dense in appearance on plain films and even more dense in appearance on CT. It's typically curvilinear in nature and typically located in the upper outer corner. Here it's demonstrated in the axial view. Sometimes two or other shunts will be placed in conjunction with another glaucoma shunt, in particular when the patient has uncontrolled glaucoma. So multiple devices sometimes are needed. Here we have a non-valve shunt that does not contain any dense material, very difficult to appreciate as kind of a curvilinear fluid attenuation, often again in the upper outer quadrant of the orbital structures. This is a valved glaucoma shunt, and you clearly see the valvular area better demarcated on the coronal view with some higher density markers adjacent to it. This patient had bilateral glaucoma shunts. No matter if you have a valved or non-valved glaucoma shunt, they tend to have a fluid accumulation adjacent to the shunt, meaning medially and laterally to the shunt. That's expected, and it's also referred to as a fluid bleb, as seen here in the coronal view and axial view. On T1-weighted sequences, this will assume CSF attenuation with no enhancement. Notice that there is no surrounding stranding or edema to suggest superimposed infection. The intraocular shunt is typically placed from superiorly into the anterior chamber. It can mimic a foreign body on CT or plain films. However, the location should be a helpful hint. Again, if you see it in the anterior superior chamber, think about the express shunt and check with the patient if they had prior surgery. These shunts are MRI compatible up to 1.5 Tesla. Occasionally, you will have a subconjunctival bleb associated with it, which is a normal finding and should not be mistaken for an associated complication. On MRI, these are very hard to see due to their small size, and typically you will appreciate it as a black dot on a volumetric acquisition. Notice that the patient had an additional shunt, beveled shunt adjacent to it, as demonstrated better on the correlative CT image. Complication can occur with glaucoma, with choroidal effusion and infection being most commonly diagnosed on imaging. Choroidal effusion represents a fluid collection that is intraocular, subchoroidal in nature. So it's, in contrast to the bleb, it's not outside of the globe surrounding the shunt. It's inside of the globe. And typically it's not located just adjacent to the shunt, but in other location, like the medial orbit, or even circumferentially, as demonstrated here on the coronal view with a wavy appearance of the choroid. Sometimes the blebs that are associated with the shunt are mistaken for an abscess, such as in this patient where the adjacent lacrimal gland demonstrate marked enhancement, but that's physiological enhancement of the lacrimal gland. Notice that there is no enhancement or stranding posterior to the fluid accumulation. In contrast to this patient where we have also a fluid collection, but notice that this fluid collection is not around the shunt, but anterior to the shunt. This would be unusual for a typical fluid bled associated with glaucoma shunt. This is truly an abnormal finding, and notice also the marked enhancement and thickening of the conjunctiva adjacent to the fluid collection, consistent with an abscess. So what are the home take points? Valved or non-valved shunt tend to have a fluid bleb just around them, not anterior or posterior to them, just immediately adjacent to them. To avoid overlooking an infection, look for potential stranding of the adjacent fat and for enhancement in unusual locations. In addition, look for subchoroidal effusion, which is a normal finding and needs to be reported. It's intraocular in nature and not like the bleb outside of the globe adjacent to the shunt. The intraocular shunts can be associated with a subconjunctival effusion, which is a physiological finding, but they can be also mistaken for foreign bodies, as demonstrated here on the plain film. Remember, if you see it in the superior anterior chamber, think about it. Could this be a glaucoma shunt and correlate to patient's history, as these are MRI compatible up to 1.5 Tesla. Last but not least, let us talk about globe prosthesis. These consist of two components: an anterior acrylic shell that is visible and contains the painted on iris, and the posterior sphere that is serving as a snapping point for the anterior shell. The extraocular muscles might be or might not be attached to the shell or the sphere. So the sphere can be non-porous type, meaning that it will be very smooth, or porous type that has small indentations on it, and this is visible in particular on MRI. Here we have a patient that is a shell without a sphere. There's no attachment of the muscles to the shell, and because of that, there will be no motion of the shell with a contralateral eye. Here we have a shell with a small sphere where the muscles are attached to the shell. So because of that, this eye will be moving in coordination with the contralateral eye. In this patient, we have again a shell and a silicon sphere, but notice that the muscles are attached to the silicon sphere medially and laterally rather than to the shell. What complication can occur with prosthesis? Again, infection. Displacement and extrusion are usually very clinically obvious and do not come to imaging, as well as endophthalmos. So infection can occur retrobulbar, meaning behind the prosthesis, and because of that, might be difficult to diagnose for the clinician. Here we have a tiny abscess posterior to the silicone prosthesis. Here is an intraoperative picture where the sphere, silicone sphere, is removed and the abscess is revealed. In addition, porous prosthesis can get infected, and because of the porous nature, they will develop air bubbles within the prosthetic material themselves. Notice that there's profound enhancement in adjacent stranding of the orbital structures around the sphere itself, indicating active infection. However, not always enhancement means infection. Here we have a patient with a shell and a porous prosthesis. As I mentioned before, this will be more speckled in appearance, as you can see here. But what is the key finding is that you have also heterogeneous enhancement of the sphere, and this is related to capillary ingrowth, which is desirable rather than infection associated with the prosthesis. Notice that there is no stranding in the surrounding or air pockets within the prosthesis to suggest superimposed infection. In addition, sometimes muscles, extraocular muscles will show profound enhancement. does not always mean that you're dealing with an infection such as myositis. This can be related to denervation of the extraocular muscles that in the acute phase will show marked enhancement and edema. This is a challenging situation for the radiologist that needs to be reported, but the main reason why we need to report it is that we alert the physician that they have to correlate to clinical findings and symptoms to determine if we are dealing with infection or denervation of the muscular structures. Occasionally, there will be complete obliteration or marked obliteration of the retrobulbar fat planes. This is often related to excessive scarring that causes endophthalmos, essentially kind of locking in of the sphere into the posterior portion of the orbital socket. This is typically not reported by the radiologist, but causes significant cosmetic and functional problems, and because of that, it's typically easily detectable by the clinician. So what are the take-home points? Enhancement of the prosthesis or muscles does not always mean that infection is present, as this could be related to vascular ingrowth. In case of porous prosthesis, you look for periprostatic inflammatory changes or air pockets to determine if superimposed infection is present, and muscular denervation can mimic myositis, and clinical distinction is key finding here. In conclusion, familiarity with expected appearance of different orbital devices is critical for the radiologist to avoid interpretation pitfalls such as abscess versus expected bleb, a hydrogel buckle that might mimic a foreign body in CT that is non-metallic in nature, or an intraocular glaucoma mistaken for a foreign body and preventing an MRI examination. Don't forget to diagnose possible complication, in particular infection, as well as post-surgical glaucoma. Here, look for widening of the anterior chamber, as this might be the first hint that the patient has post-surgical glaucoma and could potentially result in vision loss if not treated in timely fashion. And denervation versus myositis can be a diagnostic challenge on imaging and needs to be reported to the clinician for differentiation based on clinical findings and symptoms. Thank you very much for your attention. I hope that you appreciated the presentation.